level 2, when we talked about brain tumors, we talked about the symptoms being related to where the tumor occurs in the brain. Okay, we talked about that even though surgery is an option, that because of the way the brain tumors grow with their little fingers, it's not always the best option and they can't always remove all of the tumor. Remember that? But we're going to talk about 2 special tumors that cause cognition problems, or cognition, sensation, movement problems, I should say. The first one is a benign tumor, and it is an acoustic neuroma. And so if you look at it, this is the acoustic neuroma right here, and it's growing right inside the inner ear. So what do you know, first thing, what's going to be happening with this person? Balance is going to be an issue. Hearing could be an issue. Now, if you look right here, you have the facial nerve, that's cranial nerve number 5. So chewing and swallowing could be an issue. Okay, and here's your other nerve. This is the vestibular cranial nerve, and then cranial nerve number 8 for your hearing. So you can see how this wraps itself around all those nerves, and when they go to take it out, that's where your patient has the problem, because they do the damage to the nerve in the process of removing this. So it tends to compress cranial nerve number 5, number 7, number 9, and number 10. So hearing loss, dizziness, vertigo, tinnitus, ringing in the ears, and then the chewing and the swallowing is the biggest issue with those. So I gave you just a picture of the cranial nerves. I want you to know these cranial nerves associated with the acoustic neuroma. And then, of course, you remember from last time when we talked about your optic nerve, which is 1, 2, and 4, which controls your eye movement and your pupil response. So we're just adding cranial nerves each semester.
5, 7, 9, and 10.
5, 7, 9, and 10. Yeah.
Not number 8.
Oh yeah, 8. I'm sorry. Did I say 8? Yeah, 8's your hearing.
Okay, 5, 7,
Yeah,
8,
that's yours.
9, 10. No, it's 5 through 10.
5 through 10. Hearing, swallowing, chewing, and then because of where it's located, your balance. Okay? So really the treatment for that is surgical removal. It is benign, so it's not malignant. It's not going to go anywhere else. But let's say they go in there and they remove as much of this benign tumor as they can without causing nerve damage. Is that the end of the process for the patient? No, because what's going to happen to the tumor?
Come back.
Over time, it's going to grow again. So it's not a surgery is not an end all, because there's no way they're going to get it all at one time. There's a little tiny paragraph about acoustic neuromas in your book, so you can look at that and just be familiar with that. Now, the other one we're going to talk about is pituitary tumors. And we're talking about pituitary tumors that are benign, but they are in the pituitary gland right here. So if this is my optic nerve, what kind of problems do you think I'm going to have? Vision problems. So because this tumor, which this doesn't have a tumor in it, but if my tumor is growing anywhere in my pituitary gland and it's pressing right here on the optic nerve, it's going to affect my patient's vision. What else could happen if I have a tumor in my pituitary gland?
Excessive amounts.
Okay, hormone problems. So I could have SIADH or diabetes insipidus. Okay? So tell me what my patient's going to look like.
What?
Okay, well, let's talk about what's the difference between the two. Diabetes insipidus and SIADH. Tell me about SIADH.
It's overflow of fluids.
Okay, they're holding on to it. So I have fluid overload. When I go to the bathroom, my urine is going to be dark, concentrated, have sediment in it. What's my vital signs going to look like?
High.
I may have some high blood pressure, the bounding pulse. When I set my patient up at the 30-degree angle, I may see some JVD. What's my electrolytes going to look like?
You'll have hypercalcemia. High sodium.
Low sodium.
Low sodium. Remember, if I'm retaining all of this fluid, I'm diluting
The sodium.
my sodium. So I have low sodium, not really truly low, but dilutionally low. Does that make a difference to my brain?
Yes.
Right. Okay, what I really meant was just because it's dilutional, is that going to affect my cognition? Yes, it is.
Yep.
Because my brain still says, I'm not getting enough sodium. Okay, diabetes insipidus. What's that patient look like?
Tired, weak.
Okay,
and
muscle
clammy.
weakness, dry. That's the biggest thing. They're dry because they're putting out how much urine a day? Up to 20
A lot.
liters. I can't keep up with that. I can't drink 20. I can barely drink 2 liters a day. So I can't keep up with that. So what's their blood pressure going to look like?
Low.
Low. What about their sodium level?
High.
Could be on the high end. Does that affect cognition?
Yes.
Of course it does, or we wouldn't be talking about it. I mean, it's true. So you need to know the difference between these two. We don't talk about these. I say that. We don't really talk about these two again in metabolism very much. So that's where you're gonna get your exposure to them in this level 3. I actually gave you a slide with all the little side effects because I know it's so hard to go back and look them up.
So,
And it's spring break.
the pituitary tumor can give you SIADH and diabetes.
Remember that SIADH and diabetes insipidus happen because of any kind of head injury, and a space-occupying lesion in the pituitary gland would be an injury of sorts. So yes, it can cause either one of those, depending on your patient. So those are the only 2 special brain tumors that you need to know about: the acoustic neuroma and pituitary tumors. Okay. How are brain tumors normally treated?
Depends on where they're at.
Depends on where they're at.
But surgery, radiation, chemo.
Yeah, we like to treat them with radiation and shrink them, so we're removing less. We do surgery to remove as much as we can without causing any kind of neurological compromise. Chemotherapy, effective or not effective?
Not effective.
Not super effective because of the blood-brain barrier, okay? Don't get bogged down in brain tumors, okay? Spinal cord. We're going to talk a little bit about spinal cord injury and add some stuff to it that we didn't talk about in level 2. We did talk about the spinal column and the anatomy of it, so you know that it's protected by your bones in your spine. It's responsible for movement, for sensation, reflexes, things like that. Remember all these types of injuries that you can have? Hyperextension, hyperflexion. These are our compression issues. Who's at highest risk for lumbar compression fracture?
Old people.
Older people with their falls. Who's at highest risk for the cervical compression fracture?
Children. Or like adolescents.
Teenagers.
Teenagers. You know, who do dumb things when they're drinking underage. But yes, usually the younger population, and it is because of their daredevil, risk-taking lifestyle. Then you could also have an
Overflexion.
it's flexion, but it's, to lateral. And then penetrating wounds. What kind of penetrating wounds could you have with the spinal cord?
Stabbing, shooting.
Stabbing, shooting, those are the biggest ones. So you just need to know the mechanisms of injury. Not like I'm going to ask you a question about that particularly, because that's knowledge based. I don't care what you know. Here, you can use what you know. Just take care of my patient. So this little slide right here talks about, we're just going to talk about it. You don't have to memorize this or anything. But what happens is, when I have my spinal cord injury, I have a change in blood flow to my spine. That's what creates the whole problem. Because somewhere I'm having some sort of ischemia, or I'm having a bleed in my spine where the blood is taking up space and causing compression on the spine. So that causes my body to respond. Just like when you have an infection and your body starts shooting out extra white blood cells to take care of the infection, neurotransmitters are saying, hey, something's not right here, and they're really working overtime. what happens is, in response to that, they start attacking the nerve cells. So that's why when you have your initial injury, you can't say, you're never going to move your lower extremities again, initially, because once this all calms back down, you may regain some use of the extremities. The problem is, we don't want to cause cell death, and we don't want to have secondary injuries, because secondary injuries cause the scarring that make this injury permanent. So what kind of secondary injuries will we look to prevent?
Unstable C-spine.
Unstable spine, for one, because that's going to cause more inflammation, and the longer we have the inflammation, the worse the problem is going to be. What about bleeding? If my patient has a spinal cord injury, let's say they were in an automobile accident, and they have a spinal cord injury, is there a probability that they're going to have additional injuries?
Yeah.
Yeah, they may have some internal organ injuries, they may have a head injury to go with that, so they may have some bleeding. I can have bleeding internally, like let's say I ruptured my spleen in this accident. Could that cause hypotension in my spine?
Yeah.
Yeah, so now I don't have any blood flow, I got a problem. Or if the bleed itself is occurring in the spine, I'm causing more compression and I have another problem. So really, the stabilization is how we're trying to prevent other problems from occurring. This is your levels of injury right here. You remember this slide I talked to? This tells you what your deficit's going to be. So if my level of injury is at shoulder blades, you know, right here at my shoulders, can I move my arms? No. I might be able to shrug my shoulders. I might actually have some use of my hands. Have you ever seen a quadriplegic who can play video games?
Mm-hmm.
Yeah, because they have some motor, they don't have the big gross motor skills. Can this one learn to walk?
No.
He can't learn to be mobile
No.
with braces and assistive devices? Can this one learn to feed himself? Yeah. He can? He can feed himself?
And we're probably gonna be on a ventilator too, right?
Right, he can't move anything from his neck down. He's not gonna feed himself. So what I really want you to get from this slide in level 3 is, depending on where my injury is, what can I expect my patient to regain? Okay? This one, he can transfer from the bed to the wheelchair. He could probably walk with some assistive devices. This one probably could transfer, but he's not gonna walk. This one could feed himself. This one's gonna have all kinds of communication problems, can't feed himself, can't do his ADLs. So that's what I really want you to get from this slide. Based on where my injury is, what is my deficit gonna be? Okay, this is a review too. When I come upon a person who's in a wreck or whatever and had a spinal cord injury, I'm going to assess ABCs first. Does that make sense? Mm-hmm. Yeah. If I have an airway, but I'm not moving any air, like I could have an airway. I could be talking to you, but I could also have a collapsed lung. So am I oxygenating myself? So I'm assessing my airway and my breathing to make sure that I have adequate breathing. Circulation. Are you laying in a pile of blood? Can I check someone's circulation without a blood pressure cuff? I don't know what their blood pressure is. Capillary refill. Pulse. I can check a pulse. That's a good indicator that they're getting some blood from somewhere. What if my pulse is fast?
It's pumping out.
Yeah, I might have tachycardia because I'm losing blood somewhere, but I still have some circulation at that point. So that's important. GCS and stabilize that neck and spine. They bring them to the emergency room on the backboard. What's the test they use to verify a spinal cord injury? A CT. And they keep them immobilized until that CT, they're cleared with the C-spine to make sure that there's no unstable fracture there. Can I get skin breakdown? Yeah, doesn't take very long. So I've been out in the field, you know, because I was way out in the country doing whatever I was doing. Hunting. I'll say I was hunting. And they picked me up, brought me in there. I've been on that backboard for an hour. You give me a CT scan. Could I have breakdown starting already? Mm-hmm. Yeah, the back of my head. If I'm a thin person, the back of my shoulders, my butt, my heels. So you're going to assess them for skin breakdown and as soon as you get them out of traction like that. Log rolling. We talk about that, but do you know what it is?
Yep.
You know how to do it?
Yep.
No.
So when my patient tries to help me and swing their leg over,
Nope.
are they log rolling? No, I want them to roll as one unit. So if I'm rolling, I want both hips to come together so they're not to help me with their legs. That's a terrible slide. I got this from an old PowerPoint, but I wanted you to make sure because log rolling is on your syllabus. You need to understand the principle of log rolling and how you're moving your client as one unit. Can I log roll somebody completely by myself? No, I need assistance with that. Usually at least 2 people, usually 3 is at the bedside to stabilize that person and get them moved. All of these fun things right here. Now my patient's been cleared by the C-spine, but I need to have some mobilization. These 2 collars right here, the Miami J and the Philadelphia collar, are they comfortable?
Nope.
What do you think the patient's biggest complaint is?
My neck hurts.
Probably irritation.
Well, they have a headache because how many of you are used to standing like this all the time? They're sort of hyperextended and it's pulling on their neck to put the traction on their neck. So they complain. Where's this person likely to get skin breakdown?
Their jaws and their ears.
The face.
Anywhere around here, the jaw and the ear and the base of that collar in the back. So I'm assessing for that. If my patient needs an airway, can they have an airway with this? Yeah, I can have an airway. If I'm on a vent too long, can I wear this with the trach?
Yeah.
Yeah, that's why it's designed that way. This brace right here is for thoracic and upper lumbar fractures. It is a hard shell plastic. They call it a tortoise brace sometimes, but it is hard plastic. When do they need to have this on?
All the time.
While they're up and about moving around.
Anytime they're out of bed. If they're laying in the bed, they're fine without it, but anytime they're up being mobile, they need to have that on. And then the halo. What do you know about the halo?
Only the doctor changes the pressure on the pins.
Okay,
You
the
don't
pins
drive
are
it.
screwed into the skull.
They sleep sitting up.
They sleep pretty much sitting up. They can lay a little bit flatter, but 30 to 45
They can't
degrees.
remove it.
What about eating and drinking? Anything I need to think about?
Very straw because you can't bend your head down.
Okay, yeah, I can't look down because it's screwed to my head. And I can't tip my cup up or I'll have a shower every time I do, so straws. What about my bite size?
Small.
I need to have them small, cut up, make sure that I can chew them because of my limited mobility, I'm a choking hazard. Anything about infection with those pins?
Yes.
Okay. They want to clean them. Usually what they have you do is clean them with half-strength peroxide and then put like bacitracin around them to keep them from getting infected.
Do you unscrew it to clean it?
Uh-uh.
You do it around
It's screwed
it.
into the bone. You don't ever unscrew anything.
Okay. But so you just clean around it. You don't okay.
So if you do play with those and the screws penetrate the skull, is my patient opened up for meningitis?
Yeah.
Yeah, because if I can get something through the skull into the brain tissue, soft tissue, bacteria can get in there also. We don't think about this very much down here because it's not usually very cold, but what if I lived in the northern states and it was cold? Yes, the metal conducts the cold, so they teach them to wrap them with gauze to keep the metal from getting so cold into the skull.
They need a pillow.
Okay, a very flat pillow. Very flat pillow they can use. What about this? Do you think that this smells very good after days?
No.
So this stuff unsnaps from here, and you can take the sheepskin out and replace it, and then put new sheepskin underneath there and wash it. You can keep it clean because it does get kind of stinky. What about one other safety thing you need to teach them? They're going home with this thing.
Make sure they know they can't drive.
Yes, make sure they know they can't drive. They cannot drive. Now, let me tell you about my little patient at Biloxi Regional. He had a halo. I don't know what he did, but he ended up in the hospital, had a halo. We sent him home. He was a young, athletic, African-American guy. We told him he couldn't drive. The next day, I was getting Sonic tea on my way to work down on the beach, and he was driving his bicycle. He didn't drive a car. We told him he couldn't drive a car, but we weren't clear. So when you're giving discharge instructions, you need to be clear about that.
Have somebody bring the yard out. Don't do anything.
Okay, how much does the halo weigh? Do you know?
It's like, what, 40?
Probably a lot.
It weighs about 22 pounds. So on my young athletic guy, it really wasn't that big of a deal for him. But think about this: if you have an older person who has an unstable gait already, and then you put the 22 pounds on their head, how unstable they would be to just ambulate. So ambulation with them is a chore to get them up moving around. We had a lady one time at the hospital who had a halo. I'm not sure why. She was older, and she was complaining that it was killing her and it was hurting and blah, blah, blah. So we called the doctor like over and over and over. She had all the pain medicine she was going to get. And so called him back like, I don't know, the 5th or 6th time. And he said, I've already given her everything she can have. You're just going to have to tell her to deal with it till tomorrow morning. This is like 11 o'clock at night. And we're like, we don't need to tell her to deal with anything because she had unscrewed the screws. What happened when we went in the room to comfort her again, she immediately turned like this and looked toward the door. So the halo stayed and she turned, and we're like, well, that's not right. You know, so she ended up having to go back and have it re-put back on in the middle of the night. But she had it, for whatever reason, she decided she didn't want it. So you have to make sure those pins are tight and that they're clean so that the patient's not messing with it. This, well, that's a halo right there. It's just another, it comes in pieces and parts and they put it all together. This bed right here, have you seen one of those at the hospital? I think Memorial only has one in that whole big hospital. But it's called a roto rest bed. Right. And I can turn my patient because is circulation a problem for this person?
Yeah.
So if I'm laying flat on my back all the time and blood is pooling behind me, if I can even just turn them, I can get some circulation restored. So that's the roto bed. You just don't see them very often. They're not real common. They're super expensive. And now Memorial has the new bed that you can actually turn your patient upside down and the Lynette bed. Mm-hmm. But the roto bed's on your syllabus, so I wanted to show you a picture of it at least so you knew what it was. But I can really rotate my patient a lot. It's kind of like a carnival ride. They don't really care at that point. We talked in level 1 about spinal shock, or level 2. Is spinal shock normal?
Yes.
Does it happen to everybody with a spinal cord injury? Yes, it does. It is common. Happens to everybody. It is not shock referring to anything cardiovascular. It is just a term for the shock that your body endures. How do I know that they have spinal shock? What do they lose?
Sensation.
Okay, they've lost sensation because of their spinal cord injury. What else do they lose? Mobility. They've lost that because of their injury. Reflexes. Yeah, reflexes. Because if you remember, if I hold my hand over a handle, my brain tells me to move your hand. Okay? In that point, your brain is so fast. But your reflexes, when they hit your knee with the hammer, you don't have to think about that because the sensation travels up your leg to your spine, around, and back down. It doesn't have to go to the brain. So once all the edema is resolved and the swelling's down, your reflexes don't have to travel up the spine to the brain. They just travel around and right back down. So when your reflexes return, spinal shock ends. Okay? What reflexes besides the ones in your knee, your patella knee flexes?
Elbows.
Your elbows, if you have a cervical injury. Ankles. What about your bowels? Your bowels are, I know you didn't want to talk about GI, but your bowels are their own entity when it comes to peristalsis is just something that occurs. So when the tone of your sphincter muscle returns, that's a reflex. So that's how they know when your patellar reflexes and your tone of your sphincter muscle returns. They consider that spinal shock is over. I want to skip that slide. I rearranged some stuff. I'm going to give you this PowerPoint today up through what we covered today. No, I'm going to give it to you. There is a PowerPoint out there. I'm just going to tell you, there's a couple out there. One says it's from 2014. I really don't want you to be looking at that one because it's old. It's in a completely different book. But I left it on there because carotid endarterectomy is on it. But I'll move it to our new PowerPoint. I'll just unpublish it so you don't have to look at it.
And I'm sorry, you said when those reflexes come back,
They
then that
consider
means
spinal shock is over.
Gotcha.
Usually 48 hours, but it can last a lot longer depending how severe the injury is. The medications on your syllabus that we're going to talk about are the central acting muscle relaxers. This is Xanaflex. Xanaflex is a muscle relaxer specifically designed for spinal cord injury. But what are other muscle relaxers that you know of?
baclofen.
Baclofen, Flexeril, Robaxin. So you recognize the names of them, okay? Klonopin. Clonidine is a blood pressure medicine. Don't get those confused. Baclofen can be given orally, or baclofen can be given in a pump. And we're going to learn all about this in level 4. But what it is, it's a pump that's planted into your spine, kind of like an epidural. And it releases the medication to keep you from having the muscle spasticity. So, if I have a patient on these medications, what kind of things do I need to think about? Okay, safety. Tell me about safety, somebody. What about safety?
Their blood pressure, their heart rate.
Okay, blood pressure and heart rate, because I'm a muscle relaxer. Is my heart a muscle?
Yes.
Is my diaphragm a muscle?
Yes.
So if they're super relaxed, I could have a low blood pressure, a low respiratory rate because I just don't have the effort to breathe. What other kind of safety things? Okay, do not operate heavy machinery to know how this medication affects you. So yes, I don't want you driving until you know that you can take this medication and stay awake. What about falls?
Yeah.
So I give my patients some Xanaflex in the hospital, Tizanidine, and I turn their lights off because it's nighttime, and I tell them good night, and they get to go to the bathroom. Is there a lot of crap in their room they can trip over?
Oh, yeah.
Are they always going to call me for help?
No.
Probably never. So I need to make sure that when I'm giving them that medicine that I'm making sure that I'm leaving them in a safe environment. They have their call line in reach. If they have STDs on, they know to call me to unhook them to get up to the bathroom. I don't have a bunch of junk laying on the way to the bathroom for them to trip over. Our hospital room is messy.
Mm-hmm.
Yeah.
Yes, generally there's just junk everywhere. I don't understand that.
Especially when they move in.
Right. And some people, not only the crap that we bring in, they bring their crap from home and there's stuff everywhere. So safety is a big issue. What about this drug? I'm taking this drug 3 times a day for muscle spasticity. I'm having a really good day, so I'm not going to take it. Can I just stop taking this drug? No. This drug needs to be tapered down. Both of these drugs need to be tapered down because I'm going to have like rebound spasticity if I just stop taking the drug without, tapering it down and doctor supervision. Particularly baclofen, if you stop it abruptly, can cause seizures and hallucinations. So that's patient teaching right there that you need to teach them. Take it as prescribed. Don't take more than you're supposed to. Don't stop it abruptly. This is our new thing in level 3 with spinal cord injuries. Autonomic dysreflexia. And we may have mentioned it in level 2, but we didn't really talk about it. This is a life-threatening cardiac event that occurs with spinal cord injury patients, okay? And what it is, this is a bunch of words on a page. I just kept this slide because I updated it to this chart. It gives you some signs and symptoms and things. This is what I really want you to get, though, the picture. The picture helps. If my patient has a spinal cord injury at T6 or above, and they have some sort of noxious stimuli below the injury, can they feel it? So let's just say I have an injury at C7 and I have an ingrown toenail. Has anybody ever had an ingrown toenail? No. Do they hurt? Yeah, they hurt. I can't feel it though. So that's my noxious stimuli. Something down there is causing a problem, but I don't know what it is. Okay? So it can be anything. It can be a pressure ulcer. It can be an ingrown toenail. It can be, let me ask you this. Have you ever put your tennis shoe on, tied them all up, been out for an hour and said, oh my God, these shoes are killing my foot because you tied them so tight? Yeah. This guy can't feel that. Could that be a noxious stimuli? Because I'm going to bend over and loosen up my shoe. He can't feel it, but something's not right. His nervous system knows something's not right. The leading cause of autonomic dysreflexia, however, is a full bladder. So, if I know that it's a full bladder, what do you think I want to do? Yeah, I want to empty it. So, if my patient has a Foley, do you think I might want to look at the bag and see if physical therapy put him back in bed and laid the bag up beside him or hung it on the side rail, is it going to drain?
No.
Or my tech's been super busy because we're short-staffed, we always are, and the bag is pooched out like a cantaloupe, full. If it's full, can anything drain into it?
No.
Okay. What about my patient who could in and out cath themselves? But we were busy at the Mardi Gras. I had 3 beers, and it's been hours since I in and out cath myself. Could this be a problem?
Yes.
So the questions that I need to ask my patient are, when's the last time you emptied your bladder? I need to check my Foley bag for kinks or obstructions or the fact that it's up and not flowing to gravity or it's overflowing, one or the other. So the first thing I want to do, because this is what my patients tell me, I just don't feel right. Something's wrong. They're usually sweating and they're usually freaking out because something's not right. And it's up to you to figure it out because you're the nurse and you know everything. Okay? First thing I want to do is I want to check their blood pressure. Because autonomic dysreflexia has a high blood pressure. So they usually have an increased blood pressure.
So that's priority to check blood pressure?
Mm-hmm. You're going to check their blood pressure when they start acting like this. And they usually tell you, something's not right, I have a headache, I don't feel right. They can't tell you what it is, though, because they can't identify it. So I'm going to check their blood pressure. What's the one thing I want to do to help lower their blood pressure before I do anything else?
Sit them up.
I want to sit them up. So if they're in the bed, I want to put the head of the bed up. If they're in the wheelchair, I want to make sure that they're safe, because if they pass out or anything, I don't want them falling out of the wheelchair. But I want to get them from a supine position to a sitting position. Then I'm going to start checking some stuff. The first thing I'm going to check is the bladder. So do I need to strip my patient naked to see if their bladder is distended?
No.
You'll be surprised when you get to level 4 how many of you tell me you have to do that to check if the bladder is distended. This follows you to level 4, I'm just going to tell you. So I want to check the bladder. I want to check for distension. While I'm feeling, what am I asking my patient?
Does it hurt?
Is it,
Feel pressure?
can they feel anything? I'm paralyzed from here down.
When was the last time you urinated?
When was the last time you in and out cathed yourself? I'm checking my Foley as I'm seeing if they're distended. I'm looking at the bag. Have you ever seen a Foley catheter that had so much sediment that it wasn't flowing anymore? So I might have to get an order to flush my Foley with some sterile water. Those little holes aren't very big, and if you have a lot of sediment, they can get clotted off. So I want to check that. Then I want to check to see if they have any tight clothing on. What kind of tight clothing could they have in the hospital?
Socks.
Socks. If you have the skid socks on, you know what I'm talking about, anti-skid socks. What else though? What other kind of socks?
Diabetic.
Head hose. TED hose. Think about that. Have you ever taken, well, let's do this. Have you ever put TED hose on somebody? Do they always go on nice and slick and smooth?
No.
Nope. So they get kinked up around their ankles. So that's constricting. They get kinked up around their knee. That's constricting. And what about this elastic up here at the top? Is it always nice and smooth the way it should be? No. It's always rolled down, cutting in, digging in. I can't feel it. But that's constrictive clothing that's causing some sort of problem. Okay? So, TED hose, SCDs are a big thing. What if I got them on too tight? How loose are they supposed to be?
2 fingers.
2 fingers. You should be able to get 2 fingers in there to make sure that they're not too tight. They're doing the job, but they're not too tight on the patient's legs. So I'm going to check for that. What other kind of tight things could I have in the hospital?
Blood pressure cuffs on your.
Okay, if somebody put the blood pressure cuff on my leg, for sure, if I'm, from here down, and left it there for hours and hours, that could be a problem. A tourniquet, if someone was drawing blood and they forgot to take the tourniquet off. Because eventually a person who can feel it's going to say, this is kind of tight. But someone who can't feel it's not going to say. What about a patient who is working with physical therapy and they switch them over to a leg bag during the day? How's that leg bag attached to them?
By elastic.
Elastic straps. Can that be too tight?
Yeah.
So those are the kind of things that you're looking for with your patient. What about the draw sheet underneath my patient?
It's rolled.
Mine are always nice and smooth. But what if it is all bunched up and you have a big ridge across your patient? Could that be a problem?
Yes.
Yes. So it's not constricting, but it's causing a problem that they can feel. The other things, bowel movements. When is the last time you had a bowel movement? Because that's a big issue. If they're if they have a not obstruction, compaction, or they're severely constipated. How do you feel when you're constipated? I mean, I know you don't want to talk about GI, but you just don't feel good, when you are constipated. So fecal impaction is the other thing. So what I really want to do is I want to sit them up to lower their blood pressure, make sure they're safe. Then I want to start checking for things. Why do I not want to run to the phone and call the doctor first?
You can probably fix it.
Because you can probably fix it without.
Right. I can try to fix the... Here's what's going to happen. Hey, Dr. Smith, this is Marcy. I'm taking care of Mr. Jones in 607. I think he's having autonomic dysreflexia. And then Dr. Smith is going to say, well, what have you done to help him before you called me? Because he's not going to go tell me, go check and see if his bladder is full. He expects me as the nurse to know that. So I'm going to call him after the fact and say, I've done A, B, C, and D, and either his symptoms have resolved or they haven't resolved and I need to do something about his blood pressure. But I'm not going to, my first knee-jerk reaction is not going to be to run to the phone and call for help. Am I going to leave my patient though?
No.
How am I going to get paid? How am I going to get help?
Better
Yeah,
yell.
hit the call light. You know what I'm saying? Patients do it all the time. Hit the call light. Someone will come eventually. But here's your symptoms right here. Above the injury, you're going to see epinephrine. Something's wrong. You're going to see that flight or fight, something's wrong. But below the injury, everything's chill. I'm going to be pale, cool, not sweating, because I don't recognize that from below my injury, there is some sort of a problem. But the top of me knows something's not right. So can you see how your symptoms or what your patient looks like is different? So that's your new thing for level 3 to add into your spinal cord injury patient. It is potentially life-threatening. You got to do something about it. There's drugs that you can give for the blood pressure if you need to. How are you going to give the drugs most of the time in the hospital? IV. Now, can this happen anywhere, not just in the hospital?
Yeah.
Yes, normally it happens at home. I want to prevent this from happening. So what kind of things do I need to teach my patient? Yeah. Make sure that you're following the bladder regime that is established. teaching family members, make sure that clothing's not too tight, keeping track of those bowel movements and how often they have a bowel movement, and, you know, are they having constipation? And if so, what can I do?
Stool softeners.
Increase the
laxatives.
fiber, stool softeners, more water, things like that. In level 4, we're going to talk about these patients. You can actually retrain the bowels, because I'll just give you an example. I had a German Shepherd one time for years, 15 years she lived. And when she would go out at night, she would run out to the fence and she'd pee, and then she'd trot back up and come in the house, and I'd be like, no, go and poop. And that dog would go back out to the fence, and she would poop, and she would come back. You can do the same thing with these patients, given the right circumstances, to retrain their bowels. Hey, my son-in-law, he's a surgical nurse at the VA. He tells me, if I don't have a bowel movement by 5:30 in the morning, my whole entire day is ruined. So you can retrain yourself to, you know, go. So we're going to talk all about bowel training in level 4. So initially, I was worried about his airway. He's been to rehab. He's going home. Do I still worry about his airway?
Mm-hmm.
What kind of things do I worry about?
Aspiration.
Okay, aspiration.
Pneumonia.
Think about this. I hate feeding people. Y'all know that. I've already told you that. So he can't feed himself. Well, he probably can't because he's in a wheelchair. But my guy up here can't feed himself. And I'm in a hurry, and I'm trying to get him to eat. Is there a risk of him aspirating? Yes. I need to be cautious of that. I need to teach the family. You got to slow down. You got to get his attention. You got to cut the bites small enough that he's not going to choke on them. What else could be a problem with somebody who's immobile?
Oh, skin breakdown.
Well, with airway.
Oh,
Tell me airway first.
he could re-injure himself somewhere.
Just unable.
Okay, what about pneumonia? Is he at higher risk for pneumonia? Yes, because depending on where his injury is, he may not have the physical ability to cough and deep breathe. If he gets mucusy, to cough it up. Can he use an incentive spirometer? I'm paralyzed from here now. With help. How many times, well, you probably haven't because you're nursing students and they try to be nice to you guys and do stuff right. How many times have you gone in a patient's room and they're like, he won't use his incentive spirometer, and there it sits on the windowsill still in the plastic bag? Well, no wonder, because nobody taught him how to use it or helped him use it or whatever. So he's going to need your help. Quad cough is another way if they have pneumonia and they're all congested. It's kind of like the Heimlich maneuver, but when they cough, you're actually forcibly helping them to push up on the diaphragm and push out the air and the, you know, mucus, whatever. So as they cough, you're pushing, you know. It's kind of like a modified Heimlich maneuver. What about cardiovascularly? Originally, we're worried about bleeding and shock and those kind of things. Post initial, we're worried about autonomic dysreflexia. Because if I have autonomic dysreflexia, I have high blood pressure, and it can lead to strokes and bradycardia. So I'm worried about that. Mobility, you said skin integrity. Does he have mobility issues? Does every person know how to maneuver around in a wheelchair, or is that something they have to learn?
Have to learn.
They have to be conscious of curbs and sidewalks and corners, and, you know, so you have to teach them. Can somebody with no upper body strength maneuver a wheelchair?
No.
No. So you have to teach some upper body strength exercises to enhance that. Skin breakdown. I can get from the bed to the wheelchair. Am I still at risk for skin breakdown?
Yes.
What do I need to teach them?
Every 2
Him in
hours.
particular. Rotate and move. Is it, he can't feel, so it's not like he gets tired of sitting. Like, you know, when you start squirming in your seats, you're tired of sitting. He can't feel. So you have to actually train yourself to every couple hours, they say every hour, to lift with your arms and switch your position. Can you teach him that?
Yeah.
Hey, John, I was just by here an hour ago. You need to swap to the other side. Come back an hour later. You need to switch to the other side. You can teach them to consciously be aware that they need to change their positions. And bowel and bladder training. In and out cath themselves. If I have a thoracic injury, can I in and out cath myself?
Yeah, you still have to get a little.
Do I have the use of my upper extremities? Yeah. Thoracic? Yeah.
I'm thinking lower
So-
C-spine.
If it's a low C-spine, I might have to teach a family member how to in and out cath my patient or do Foley care, things like that. So those are the kind of things I want you to think about. Safety and preventing complications for your spinal cord injury patients, okay? What time is it? Good, we have enough time to get through what I want to get through today. So when we come back, we're going to do all strokes and head injuries. Great. Oh, yeah, and I took Miss Cooper's quiz, y'all. I don't know where she got some of those questions at.
Yeah, it was a little unusual. On ATI, that thing is hard.
I know.
What is happening right now?
I took it the other day, me and Miss Bates. I'm like, where'd she get these questions at?
Some of them, I was legit like, that's not how anything happens.
Well, it's how
So you gotta get what, an 84 on it?
Yeah, you can. It's a lockout. I mean, I know they rearrange the questions every time you take the test, but
Yeah, but it locks you out for 6 hours and then it doesn't tell you or rationality.
oh, I could see the rationales, but I
It
guess
wouldn't
because I'm
give
in
me
instructor
anything,
mode.
it wouldn't tell me if I was right or wrong, it just kicked me out.
She
and
was
then
hoping
6
that
hours later-
she was hoping that yours did that. Okay, spinal cord tumors. The reason we're throwing this in here is because is my patient's deficit, if I have a tumor at T2 or I have an injury at T2, are my deficits the same?
Yeah.
They're the same. The difference is it depends on how fast my tumor's growing, how fast you see the symptoms. So the way I'm going to take care of this patient, depending on their level of injury, is the same. Okay? The reason this is up here, straight from level 2's PowerPoint, is because it's on your syllabus. What do you know about spinal cord tumors? How do they treat them?
Not recurring back pain,
Okay,
Like
recurring back
paralysis?
pain.
or like numbness or something like that.
surgery or radiation.
Okay, but she's talking about symptoms. You might have some paresthesia, like if the tumor is in a location where you have paresthesia in your fingers and toes. Might I have bowel and bladder problems? I might have some pain. Things like that. Treatment. Radiation is the #1 choice of treatment because I want to shrink the size of the tumor before I go in there and dig around doing surgery removing the tumor. Chemotherapy, does it work?
Well, it's surrounded by that fluid.
It's very limited because of the blood-brain barrier. So they will use it intrathecally, like when they go in, just like an epidural, and leave the catheter in there and infuse the chemo through the spinal cord that way. But systemically, it doesn't work. So radiation, the goal is to shrink that tumor and then remove as much of it as possible without causing a deficit. Because if I have a lumbar tumor and they go in there and they start taking it out and it's all wrapped around my spine, could I lose the ability to walk?
Yeah.
So shrink it first and then take out as much of the tumor as you can without disrupting the spinal cord tissue. Do you have any questions about spinal cord injuries? I mean, largely it's a review in here, except for autonomic dysreflexia is new. Do you have any questions about it? In your book, you're going to see something about neurogenic shock. Don't worry about that. That's in level 4. That's a whole different thing. So you should know about spinal shock, and you should know about autonomic dysreflexia. You should know about how to provide safety for your patient and prevent complications from occurring in that patient. That's what you really need to focus on. Okay? In level 4, we'll talk about neurogenic shock, and we'll talk about the long-term rehabilitation of the spinal cord patient. Let's talk about multiple sclerosis before we go on spring break, okay? This is mostly a review too. You have multiple sclerosis quickly in level 2. I know you don't remember anything because level 2 is a blur, but we talked about it in there. So we're going to build some of it back in here and add a couple new things, okay? We're going to talk about this guy right here. He's 32 years old, and he's being admitted to the floor with symptoms of multiple sclerosis. So, tell me, Matt, What's one symptom of multiple sclerosis? Okay, they can have some constant pain. What affects their pain mostly? What's the biggest effect on their pain? Temperature and mobility are the biggest things.
They could lose their balance.
Okay, they have gait issues. They can lose their balance. What else?
Speech problems.
Speech problems. Well, I was talking, you don't understand me. Do I have understanding problems?
Like communication issues.
I have communication issues, but it's not a type of aphasia. It's dysarthria. My muscles in my mouth and tongue can't do what I want them to do to get the words out. So their speech is usually kind of garbled and slurred and real thick sounding. You know what I'm saying? It's not a Broca's aphasia or Wernicke's aphasia. It's more to do with the muscle of my mouth. What other symptoms can they have?
Tiredness.
Okay, tiredness. Bowel and bladder problems. Can they have those?
Yeah.
So if every single person in this little pod right here had multiple sclerosis, would they all have the same symptoms?
No.
No. What's it depend on?
How fast, how severe?
Okay, how fast it progresses. What else?
How damaged the myelin is.
How damaged it is, but which area? Where is it occurring? Is it occurring in the nerves that innervate the bladder? Is it occurring in the nerves that innervate the cranial nerves that do your teeth and chewing and talking? So it just depends, because all 6 of them could have multiple sclerosis. This one could have balance issues. This one could have bowel and bladder problems. It just depends on where it's affecting your neurons at.
And where this is damaged, there's no going back.
Right.
That's not true. That's not true.
You can delay it though.
Eventually, I'll show you the slide in a minute. Remember what happens here? This is normal. What is the myelin sheath made out of?
Protein.
Fats. It's fat. That's why your nerve impulses go so quickly. Here in multiple sclerosis, I got big chewed up areas where the nerves don't conduct as well. That's the problem. It's the body attacking itself. It's an autoimmune disease. Okay? With autoimmune diseases, do you have periods of exacerbation and periods of remission? Same thing with this. And you guys, this slide right here, you guys talked about these. Oh, we didn't talk about vision. Let's talk about vision. What is nystagmus?
Whenever your eyes are constantly.
Yeah, they're constantly moving side to side. Can you control that?
No.
No, they can't control it. They may have some blurred vision, diplopia, where they have double vision. What am I going to teach my patient to do about that?
The iPad.
Eye patch. Do I want them to always wear it on one eye?
No. Switch it.
Alternate, right. We talked about dysphagia and dysarthria. Okay, chronic progressive autoimmune. So it's never going to go away, but I can treat the symptoms and I can maybe slow down the progression of the disease. Usually it affects women more than men, and usually they're diagnosed somewhere between 20 and 40 years of age. They do attribute it to an autoimmune disorder, but your book says that, there's exact causes unknown, like most things. Okay, so he comes in, he has these symptoms: urinary urgency. He was treated for an STD because he's got a terrible girlfriend. Just telling you. He has some.
I gotta be the girl.
Because later he tells you he has a
Oh,
girlfriend.
okay.
He has some episodes of fuzziness in his vision, flashes of light, numbness and weakness in his legs, his right arm, numbness in his legs. Anyway, he's got all the problems. He's got them all. Okay. So this is what you were talking about right here. This is the normal person who's first diagnosed, okay? And they usually progress on this track for about 10 years, where they have an episode where they have an exacerbation of symptoms and they go back to the baseline. Because for a period of time, your myelin sheath can regenerate itself and re-heal itself. But then as the disease progresses, usually about the 10-year mark, they come to this one where they have an episode and a little episode, and then they never go back to their baseline. Okay? So usually for about 10 years, your body can regenerate the myelin sheath and your symptoms get better. And they can go for long periods of time, like a couple years in between episodes. That's why it's so hard to diagnose, because you know how hard it is to get into the doctor. Like, it's impossible to get an appointment. So by the time I get an appointment, my symptoms have resolved. And then what are they testing? It takes a long time sometimes to diagnose this. This one right here is usually happens in male patients and usually happens in people who are older, and they just never go back to their baseline. It just gets progressively worse. But the ones I want you to be most concerned about are the two at the top, because this is normal for the first 10 years, and then your body just starts getting tired and you never go back to your baseline. Okay? So anyway, your little boy here had all the problems that he had. Here's our diagnostic tests. How are we going to diagnose this? With an MRI. They're looking for plaques. And remember, when we're talking about plaques on your myelin sheath, I'm talking about missing places. Because when I'm talking about plaques with cardiac, what am I talking about?
Like full.
Build up of the fats and the cholesterol. Here, I'm missing pieces. So the word plaque is used, but it has the complete opposite meaning of cardiac. They can do cerebrospinal fluid. Sometimes there's increased protein levels, but the definitive test right here is the MRI that shows the presence of plaques. So if it took me forever to recognize there was a problem and go to the doctor and my symptoms have resolved, are they going to find plaques when they first do the MRI? So that's why it takes sometimes a long time to get a diagnosis. We talked in level 2 that the goal is to modify the course of the disease so that you can go for longer periods of time without an exacerbation, and each exacerbation is less, okay? So that's what we're going to talk about. Down here, who helps you take care of this patient? Everybody, because you cannot do it by yourself. I am not a speech therapist. I hate feeding people. So I'm not the one to do a swallow study and say yes or no, you can't swallow. I'm not a physical therapist, although I think I should have been, because I like inflicting pain a little bit. And when I went to rehab with my mom, it was kind of fun to watch them. But I learned a lot from physical therapy, but I'm not a physical therapist. So I can't be the expert on that. I'm definitely not a counselor, okay? You probably don't do that. But does this person need counseling services? Yes, they may need a lot of resources from the community. What if I'm diagnosed with multiple sclerosis and I live alone? Might I need some help? Yeah. I might need transportation to and from appointments. I might need Meals on Wheels. I might need somebody to come in and clean for me because I can't always do it for myself. So things like that. PTOT, speech, social services. Yeah, I'm not a social worker either. I wish I kind of was, though, because they have a wealth of knowledge about resources. Here's your medicines. These are the new medicines that we're going to talk about. Immunomodulators. Let's talk about those real quick, because you know about these immunosuppressants. It doesn't really matter what they are. What do immunosuppressants do?
Suppress your immune system.
They suppress the immune system, so they shut it down so that your exacerbation can be over. What do I need to teach my patient?
Stay away from sick people. Stay out of crowds.
Right. You all know about these. Immunosuppressants. Stay away from sick people. Wash your hands. If I'm the nurse taking care of you and I'm sick, I need to protect you from the germs that I have. So I need to wear a mask or wash my hands or whatever I need to do. So we don't really have to talk about these except for you to recognize the different names. Methotrexate's the one that they use a lot. Solumedrol for an exacerbation. How do I give solumedrol? IV. So I need to make sure that I'm giving the right dose. What's the other thing I need to teach my patient about these? If you're going home on prednisone, don't stop taking it abruptly. We're going to taper it down.
Yeah.
Okay, I don't want you to get sick. Stay away from the public. And blood sugars. If you're a diabetic in particular, it's going to raise your blood sugar. So then, our new medicines are these, and these are the modulators. Okay, so modulators work in a kind of funny way. They can suppress the immune system, or they can build up the immune system. And what I mean by building up the immune system is they act as a decoy. So when the T cells are attacking the myelin sheath, this is a decoy. And it attacks it instead of the myelin sheath. It gives the myelin sheath time to recuperate. There's some things that you need to know about these, though. Your patient cannot get vaccinations when they're on these drugs. Okay? So especially live vaccinations, they cannot get them. The top one is given in a clinic. It's given IV in a clinic. Your patient has to be monitored the whole time because there's a very high risk of anaphylaxis with that. It's just a pretty brand new release drug, and so it's still given in like an infusion clinic. Fingolimod is a pill. Your patient can take it home, but you got to do some patient teaching with it. Because aside from the infection thing, fingolimod can affect your heart rate. So you're going to teach your patient to monitor their heart rate because it can cause bradycardia. There's like 2 paragraphs about these medications. Just read over them. I'm not going to your drug book to find questions, okay?
Which one was that you said?
Fingolimod causes bradycardia. Some of them can cause, you don't have to memorize this name. It's a viral infection. It's called progressive. What's that mean? Keeps getting worse. Multifocal, meaning multiple problems that it can affect. Leukoencephalopathy. What's encephalopathy? Your brain. So it's a viral infection of the brain that causes non-reversible deficits for the patient. So that is the top one. That's why it's carefully monitored to give it.
Oh, yeah.
Okay. Bradycardia, let's see. Glatiramer acetate, it decreases the relapses of the disease. So it gives you a longer period of time in between, but it doesn't modify the disease progression. The disease is gonna progress, but it gives you longer periods of time in between your relapses. All of these drugs in patients that take them can cause an increased risk of suicidal ideations. So let me ask you this. If you are newly diagnosed with multiple sclerosis, you're having some mobility problems, you're peeing on yourself, and you can't see anymore because everything's double vision, do you think you have a problem with depression?
Mm-hmm.
Yeah. Depression is a big problem for these patients. So if I'm giving you these medications and they can increase your risk of suicidal ideations, they have to really be monitored psychologically for that kind of thing. There's our immunosuppressants. Ditropan. What's ditropan for?
It's I forget, so it's for your bladder, right?
It's for your bladder. So this is one of the medications that they use to help patients with urinary incontinence because it controls that smooth muscle over the bladder and helps with that. This was just part of the case study. You don't need to really know about ditropan, but it is one of the medicines that they're all on. I'm sorry, I should take that one out.
You said it's antispasmodic.
Antispasmodic for the bladder. So if I'm caring for him and I'm talking about activity intolerance, which one of those do you think is the most important one? Don't say D, because the answer is not D. Of course, I don't want my patient to get hurt. Okay. D. C.
C.
Okay, if I am a patient and I say, well, if I rest and if I do this and I do that, I'll be better. Is that more effective than me actually participating in my care?
No.
Because even though this patient is debilitated, I want them to do as much of their care as possible without them being exhausted. So I need to give them the opportunity to participate in their care. Does some of them not want to participate? Yes. So they have to be encouraged to participate in their care. But I really want them to participate in activities of daily living. What kind of things am I going to teach this person so that they can function? Temperature changes is one of the big ones, okay? They need to avoid temperature changes. So when your patient says, well, when I get home from the hard day of work, I just want to sit in the hot tub. Is that a good option for a patient with multiple sclerosis? No, because that temperature change, particularly the heat, exacerbates their symptoms. What else do you think I might need to teach them? What about exercise? Don't overexert yourself. Does that mean they can't do anything? No. They could light swimming. I'm not saying competitive swimming, but light swimming. What about yoga? Or simply walking? So I want them to do some sort of activity. Do they need to go to the eye doctor?
Yeah.
Yes, because if I have vision problems, whether it be a change in my vision or whether it be double vision or the nystagmus, the ophthalmologist can give me some recommendations to fix those problems. Social services. Do I need to be embarrassed to go to social services? Nope. They need to become my best friend because they're the ones with all the knowledge to all the resources that I might need. So those are the kind of things. So stress, yeah, I know that's super simple. You just need to get your stress under control. All right, I will when I graduate. Nope, you won't, because then you'll have a job and you'll be stressed out again. But that's really, we say that all the time. You're just stressed out. You just need to relax. Is that easier said than done?
Yeah.
It really is. Sometimes it's almost demeaning, when
Right.
you don't know what I have going on in my life and you're telling me to relax. So temperature changes though. What about this?
Bacteria?
Those are little bacterias.
Getting sick.
What can they do? Can they cause an exacerbation?
Yeah.
Yes, because if I get an infection, I can trigger an exacerbation. Overexertion we talked about with the exercise. He looks kind of wiped out, but they need some sleep, things like that. Okay, after testing, this is about his depression. See, I told you he has a girlfriend, y'all. His girlfriend's been unfaithful. He doesn't want to tell her because he's afraid she'll leave. Because depression is one of the biggest things. Besides their symptoms and their lack of control over their body, their family members don't know how to deal with it. Like, let's just say it was his wife, and he is the sole supporter of their family, and now she's got to go get a job. Well, I think everybody should be working myself, but that's just me. But I mean, it's a big change for the family. So depression is a big deal. So what are you going to do with that if your patient tells you they're depressed or my family just can't take care of me anymore. I don't know what I'm going to do.
Well, I mean, I would talk to the
Huh?
patient first.
Get a referral.
What did you say?
Hear them out.
Okay, you're going to hear them out. You're not going to cut them off. It's not that bad. It's not that bad. You're just going through a period. You need to hear them out and hear their honest feelings. But they do need a referral to some sort of counseling, psychiatric, whatever. Because a little bit of Wellbutrin can go a long way sometimes. You know what I'm saying? So those kind of things. And then you want to point them to the resources that are available. Multiple Sclerosis Society, we don't have one dedicated just to Mississippi. We're combined with Alabama. But we have local, right, we're the landmass. We have local places that can help people who are going through the same thing. And does it sometimes help to talk to somebody who's going through the same thing? Yes. I'll just give you an example. Unless your spouse is a nurse or in nursing school, do they truly understand
Nobody else.
what you're going through?
No.
Nobody else.
So the same is true if I have some sort of a chronic illness or some sort of an illness. If I can talk to other people and I can say, this is what the problem I'm having is, and they said, oh, well, that happened to me, and this is what I did. Can that be helpful? Yeah. Does it take a lot sometimes to convince people that a support group is helpful?
Yes.
People don't want to ask for help. So the patient needs to understand that there is help available, and they need to know, unless you're in nursing school, then reach out to your mentor. So, but anyway, I mean, seriously, they need to know it's available, and when they're ready to get the help that they need direction on how to get there and what they need. All right, y'all have a good spring break. We're going to talk about head injuries and